Hi, my name is Angela Hensley. This project will review the clinical picture evidence and advanced nursing implementations for pain assessment and interventions in patients who are mechanically ventilated. This project is in partial fulfillment of the oral comprehensive examination for my Master's in Science in Nursing with a dual acute care and family nurse practitioner focus at Colorado State University, Pueblo. The PICO question I'm addressing is, in patients on mechanical ventilators in the ICU, does standardizing the use of the critical care pain observation tool compared to no standardized pain scale improve patient outcomes? Some of the patient outcomes that will be addressed are pain control, length of intubation, length of ICU stay, and ventilator complications such as pneumonia. To address and discuss this PICO question, I will present a case study. JD is a 70-year-old male who presents to the emergency room via ambulance after being involved in a motor vehicle accident. The APRN evaluating him learns that he was a restrained driver and involved in a head-end collision with another vehicle. He is conscious and complaining of severe chest pain, difficulty breathing, and generalized weakness. His past medical history includes hypertension, COPD, type 2 diabetes, and hyperlipidemia, and he is a current half a pack a day smoker and socially drinks with his wife on the weekends. His vital signs and pertinent physical exam, which includes bruising, crepitus, and tenderness to the left chest, prompt you to order a chest x-ray, which indicates multiple left-sided rib fractures. You also decide to order a chest CT, which confirms the rib fractures and also shows bilateral emphysematous changes, which are consistent with COPD. A CBC, CMP, and lactate are also acquired and are all within normal limits. In addition to these, an arterial blood gas is also performed while the patient is on 5 liters nasal cannula, which shows mild respiratory acidosis. While in the ER, despite supplemental oxygen, JD continues to have shallow and labored breathing and has increased confusion and hypoxia. He is eventually advanced to a BiPAP and then is unable to tolerate it and ends up intubated and sent to the ICU. On hospital day 3, JD appeared to be agitated. He had facial grimacing, was restless, had tense muscle tone, and was dysynchronous with the ventilator. He failed his spontaneous awakening and spontaneous breathing trials, and the nursing staff increased his sedation. The advanced practice care provider who was caring for him that day was told that JD was too agitated and he did not tolerate coming off of sedation, so JD remained sedated for the rest of the day. The next day, on hospital day 4, I came in as the critical care advanced provider caring for JD, and when conducting a chart review, I noticed a variety of pain scales, including the self-reporting pain scale, which had only been charted on once a shift. He was sedated with propofol and fentanyl drips, and he has not received any additional pain medications, even though he has multiple rib fractures. I added scheduled acetaminophen and lidocaine patches and consulted anesthesia to evaluate for a continuous epidural infusion, which was later placed, and the continuous fentanyl drip was stopped. I educated his nurse to utilize the CPOT pain scale and to assess and document this at least every 4 hours and to inform me if JD had a score greater than 3. While caring for JD and all my patients, I will utilize Watson's theory of human caring. This theory is important for APRNs, especially those working in critical care, as it emphasizes the importance of treating each patient as a unique individual rather than simply as an object. This theory allows healthcare professionals to provide a caring, holistic, and individualized approach to patient care because every patient is unique and should not be treated as an object. When speaking with his family, I remember that all patients and their families have different ideas, perspectives, and belief systems, that need to be honored and, if possible, incorporated into their care. I will develop and maintain a helping, trusting, and caring relationship and encourage them not to lose sight of JD's belief system, spiritual practices, and needs. I will act with caring intentions, compassion, and kindness to promote health and healing. Interprofessional collaboration is crucial for providing safe, high-quality, and personalized patient-centered care for individuals who require mechanical ventilation. To enhance patient outcomes, I would establish a team-based approach involving nurses, physicians, pharmacists, and other specialists in daily interdisciplinary discussions. This collaborative effort will ensure that JD receives a comprehensive and individualized care plan that includes pain management, particularly since he is a nonverbal patient due to the endotracheal tube. Encouraging shared decision-making and involving the family will help ensure that his care is tailored to meet his needs, preferences, and beliefs. By fostering a caring and supportive environment where each team member's role is valued, we can ensure that patients receive safe, personalized, high-quality care that promotes healing and improves patient outcomes. All of the listed associations recommend frequent assessment of pain. According to the Society of Critical Care Medicine, pain should be assessed at least every 4 hours and as needed. The latest 2018 guidelines for managing pain, agitation, sedation, and delirium, and sleep disruption in the ICU stresses the importance of regular pain assessments. The CPOT is suggested for patients who are unable to communicate their pain. These guidelines prioritize pain control over sedation to improve patient outcomes, emphasizing the use of both analgesics and sedative medications. Sedation should be minimized, and a patient's pain should be assessed before considering sedation. These guidelines also recommend the use of a multimodal therapy, such as ketamine infusions, gabapentinoids, NSAIDs, acetaminophen, and regional anesthesia to treat pain in critically ill patients, favoring the use of analgesia over sedation. Therefore, it would be appropriate to prioritize JD's pain treatment in order to reduce the sedation he is receiving. When patients are less sedated, they are less likely to experience ventilator-associated events such as vital sign changes, prolonged intubations, lung injuries, pneumonia, thromboembolism, or muscle atrophy. These clinical practice guidelines aim to minimize the duration of intubation for patients and thus reduce potential harm associated with mechanical ventilation. Standardizing the use of the CPOT and assessing pain at least every 4 hours and as needed, and including these values in a patient's chart can help mitigate harm. Since sedating patients first is a current practice among my colleagues, I conducted a literature review to examine the effects of standardizing the use of the CPOT and to assess its potential impacts on patient outcomes. One article that was found was located in the BMJ Open Quality entitled Using the Model for Improvement to Implement the Critical Care Pain Observation Tool in an Adult ICU. The purpose of this article was to improve the frequency and treatment of pain in those who were unable to communicate or self-report. They utilized the CPOT to assess these patients and used an analgesic-first approach when prioritizing pain management and did this over sedation. This was a quality improvement project that utilized the Plan, Do, Study, Act cycle, was a level 4 design level, and it included 65 ICU patients using the CPOT, which increased the nurses' accountability and autonomy in treating their patients' pain. The study also found that better pain management may lead to a reduction in sedation. However, some of the weaknesses included a small sample size and a single location and was conducted in an ICU that only had 7 beds. The purpose of an article found in the Journal of Trauma Nursing was to explore the impact of implementing the critical pain observation tool on pain management practices and clinical outcomes in mechanically vented trauma patients in the ICU. Specifically, the study aimed to determine whether the use of this tool improved pain assessments, identification of pain episodes, administration of analgesics, and reassessment of pain after an intervention. Additionally, it examined whether these changes led to better clinical outcomes, such as a reduced duration of mechanical ventilation, fewer complications, and shorter ICU stays. This article also highlights the importance of a proper pain management in the ICU patients who cannot self-report. It also emphasized the need for a valid behavioral pain scale such as the CPOT to ensure pain is dedicated and treated effectively. Ultimately, improving patient recovery and reducing long-term complications is the goal. The study suggested that the use of the CPOT can lead to more frequent pain assessments, better identification of pain episodes, and improved pain management, even when the administration of fewer analgesics is given. Additionally, the efficiency of pain intervention improved, and there were fewer complications and a trend toward a shorter ICU stays in the post-implementation group. While the results were promising, further research is also needed to confirm the long-term benefits of utilizing the CPOT in the ICU settings. Again, the weaknesses of this study included a small sample size and only included 30 medical files, and there was no control group. Another article that was found was located in the Journal of the New York State Nurses Association. The purpose of this article was to standardize the use of the CPOT in nonverbal patients in an ICU to improve pain management. The design level was a level 5, and it found that it had improved patient assessments and relief with interventions, and enhanced patient comfort, decreased the length of time patients spent intubated, improved ventilator weaning complications and process, and also found a reduction in ventilator-associated events such as pneumonia. The final article was located in the Journal of Critical Care Medicine. The purpose of this article was to transition away from the FLAC scale and to standardize the use of the CPOT. It was a level 4 design and utilized a retrospective observational study. The findings showed a clinically significant and relevant trend in increased use of analgesics and reduced sedatives that were administered when utilizing the CPOT when compared to the FLAC scale without any negative patient outcomes. As with the other reviews, this also included a small sample size and only included 37 patients, and there was no randomization or control group. While conducting this literature review, there were noted to be several research gaps identified throughout these studies, including a need for long-term outcome data and inconsistent findings on the use of analgesics. The long-term outcome data. Many studies implemented pain assessment tools like the CPOT, but they often lacked follow-up on long-term clinical outcomes, such as the development of chronic pain, post-traumatic stress disorder, addiction, dependence, or abuse of these medications. There was also inconsistent findings on the use of the analgesics. Some studies reported that an increased amount were given, while others noted a decreased amount, which suggests a need for deeper investigation into what contextual factors affect these outcomes. These gaps provide avenues for further research in pain management and ICU care. These gaps can also be addressed and expanded into the outpatient side too to evaluate any long-term complications with the use of the analgesics and utilizing angilosedation first. The implications for a nurse practitioner from the articles reviewed emphasize the importance of implementing evidence-based tools like the CPOT to enhance pain assessments in non-verbal patients. For nurse practitioners, adopting these practices involves ensuring that their clinical assessments are accurate and lead to timely, appropriate interventions. Furthermore, nurse practitioners must work closely with multidisciplinary teams to ensure comprehensive pain management. Integrating Watson's theory of caring, we should focus on holistic care, which addresses both physical and emotional needs of the patients while fostering empathy and trust in their interactions. This approach helps to improve patient outcomes, reduce complications from inadequate pain management, and enhance an overall patient experience. Additionally, we have the responsibility of guiding other healthcare team members in utilizing these tools effectively and ensuring consistency and quality of care across different providers. As an AG, AC, and P, we will remain up to date and review current evidence-based practices and advocate for positive changes, such as like JD needed when utilizing the regional block to allow him to breathe with all his rib fractures and help prevent pneumonia. On the FMP side, we can assess for complications associated with intubation, such as post-traumatic stress disorder, acquiring adequate pain management in these patients to help them continue with their activities of daily living, and also administer screenings to ensure that the patients are not becoming dependent upon opioids or other addictive medications. The use of evidence-based decision-making using technology provided me to make informed and objective and timely decisions to improve JD's outcomes. Technology-driven tools such as imaging, ABG analysis, mechanical ventilations, the CPOT, and electronic health records ensure that every aspect of his care is aligned with the best evidence-based clinical practice. This integration of technology and evidence-based care improves accuracy in diagnosis, improves interventions, and enhances patient safety throughout the course of their treatments and hospital stays. The quality improvement initiative outlined in this case study are focused on three main areas: improving pain management, preventing complications related to mechanical ventilation and immobility, and enhancing communication. These initiatives aim to enhance patient safety, clinical outcomes, and the overall quality of care for critically ill patients with complex conditions such as COPD and trauma. This will be achieved by standardizing the CPOT to assess a patient's pain at least every 4 hours. It will also utilize technology to ensure that these scores are documented. Communication will be enhanced because when a patient is experiencing pain, the nursing staff must inform the APRNs about this. That way, something more can be ordered to improve the patient's pain, rather than just increasing their sedation, which could potentially prolong the length of intubation. Additionally, this new quality improvement initiative will emphasize the use of a multimodal approach to pain management, minimizing sedation, and preventing ventilator-associated events. Numerous studies have shown that using the CPOT to standardize pain assessments for nonverbal ICU patients leads to better patient outcomes. Key findings include improved pain management, reduced use of sedatives, and decreased time spent on the ventilator. The implementation of the CPOT has been found to result in more consistent and effective pain assessments, leading to fewer sedative administrations and more appropriate analgesic interventions. This approach improves pain control without causing oversedation. Studies have also determined that utilizing the CPOT reduces the need for sedation, which shifts the focus of pain management to prioritize patient comfort through appropriate use of analgesics. It is important for healthcare providers to recognize that even routine care, such as oral care, can cause pain for patients, which may manifest as agitation. Thus, effectively managing pain can reduce the need for sedatives. Research indicates that patients whose pain is better managed with the CPOT are more likely to spend less time on the ventilator, have shorter ICU stays, and experience fewer complications such as pneumonia or delirium. Watson's theory of human caring provides a theoretical foundation for the use of the critical care pain observation tool by emphasizing a holistic, patient-centered approach to care. This theory advocates for treating patients as unique individuals with their emotional, spiritual, and physical needs. When adapted to the ICU patients who were nonverbal and mechanically ventilated, Watson's framework highlights the importance of empathy, individualized care, and interdisciplinary collaboration. The CPOT enables healthcare providers to assess nonverbal cues of pain, such as facial expressions, muscle tension, which align with Watson's emphasis on observing and responding to each patient's unique expressions and experiences. By using the CPOT, interdisciplinary teams can consistently monitor and manage pain, ensuring that the patient care is holistic and compassionate, thus improving patient outcomes. Implementing the CPOT in daily ICU practice can help improve pain management in mechanically ventilated patients. This can be achieved by standardizing the use of it for assessing pain, implementing a multimodal pain management, and following evidence-based guidelines. The CPOT provides a standardized and validated method for assessing pain in patients who are unable to communicate verbally. Regular pain assessments using this method can ensure a timely and accurate pain management, reducing the risk of undertreatment. Research also supports combining the CPOT with a multimodal analgesic approach, such as acetaminophen, lidocaine patches, and epidurals, instead of relying solely on sedatives. This change can help reduce complications associated with prolonged sedation, such as ventilator-associated pneumonia, atrophy, and delirium. The Society of Critical Care Medicine guidelines recommend frequent pain assessments using the CPOT for ICU patients, and adhering to these guidelines can help reduce the length of intubation and ICU stays, directly benefiting the patient outcomes. In conclusion, standardizing the use of the CPOT in mechanically ventilated ICU patients improves outcomes. It provides consistent and accurate pain assessments, reduces unnecessary sedation, and improves patient recovery. Theoretical support from Watson's human caring theory emphasizes the importance of empathy and individualized care, and practical evidence also supports the use of integrating the CPOT into routine ICU protocols to improve pain management and improve clinical outcomes.